No, so I was working with Lauren in Lawrence Bay the other day, and with Christina as well, just kind of going over some different injections, and everyone's kind of doing different stuff. Not that any of it's wrong, it's just not what they're the students are learning in lab. So I think the students are getting confused too sometimes on why they're failing, because someone told them to do this, someone told them to do that. And it's mostly the PSA and the IA, because those are kind of the two that the technique is really a little more sensitive on. So with the PSA, the students are taught the 45, 45, 45 for their angulation, coming up over the shoulder in line with the corner of their nose. Now, a lot of the students on the non-dominant side have trouble getting that correct angulation. So in lab, we teach them that once they touch the tissue, they can't move the syringe, they can't redirect it. And I know that I was talking to Lori the other day, and Debbie says it's okay if they just bury the bevel and then they can redirect to get the correct angle. And I think a lot of the reason in lab why we teach them just not to do it at all is because a lot of the students in lab, when they bury the bevel, they've already buried half the needle. So we don't want them to move it. So I think in clinic, once the students have done more injections and are more comfortable with it, understand kind of, burying the bevel is literally just burying the bevel, then it is okay for them to redirect to get that correct angle once they're in the tissue. But I think it depends on the student too, so I think we just kind of have to be aware of that. I think the other thing is that a lot of the students are just kind of, with the PSA, they go in and they're just like, oh, this is where I'm going to inject. They've kind of forgotten about finding the actual correct spot with the contip applicator going back along the second molar. So I think it's just important that we try to remind some of them that they still have to continue to do that. I was working with Han today, and she did a great job with it, actually. She was like perfect. Couldn't have asked for her to do it better, so that was good to see that. So on the IA, a lot of the students, like I said, when they bury the bevel to give the 10 drops, they have already, inserted half the needle and they're just injecting solution at that point. I was working with Nick the other day, and that's kind of what he did. But Nick, like some of the other students, he comes in just really, really quick, really like, and I think a lot of students get nervous, so they don't even really know what they're doing. And like if Nick were to miss the injection site, he would just like stab someone with the needle.
I had a talk with him last week. I said, you're gonna have like a situation in clinic that you don't want to have. And he said, oh, I already stuck myself last. I'm like, that's exactly what I'm talking about.
Yeah, and I think, I don't know if it's because he's nervous or what is going on with him, but I think with students like that, I think like maybe just having him kind of take a step back before he starts and just trying to calm him down. And because I know you try, and I know he's got a lot going on, but I've seen it with a couple of students where they get really excited, I guess.
I was just gonna say, we don't, for the administering the counting to 10, maybe Nick is someone who really does need to do that, because we don't always do that with everybody. If they're, once they've like get into patient care, we don't tell them they have to do that, but he's probably someone that we need, or anyone else who's approaching it like that, we need to tell them they do need to do that.
Yeah.
Because that would at least help him to kind of catch his breath a little bit before he advances the needle.
And I think that's what it is. I think he's just, they get so nervous, they get so excited, they just want it to be over, and so they're just kind of rushing through it, and obviously we don't want them to stick themselves. So hopefully that doesn't happen again. And then just reviewing with students what happens if they're not contacting bone on the IA, or if they're contacting too quickly. They should know how to redirect, either coming up towards the canine or going back towards the molars, depending on what happens. And then if they don't contact at all after redirecting, that they have to come out and go up a little bit higher. I think the thing that the students do the most is they start out too low, so they're never going to get the right target. So I think a lot of them, I was working with Christine the other day, and I had Bobelle just, when she didn't contact bone, I just had her come out and go up a little bit higher, because she just wasn't, and it's not wrong. I think that they think that they find the right spot and it's a little too low. So I think just being aware of making sure that they are up high enough is going to help them kind of get into the right spot a lot more often than maybe that they are. And the other thing that we talked about with Bobelle was the quarter turn of the syringe. I know some instructors are saying that they just have to turn it just a little, so that in theory just the bevel turns a quarter. In lab, we do teach them to turn so that we can see the whole syringe turning a quarter, because a lot of them will think that they're turning a quarter and they're just moving the thumb ring, or they're just not really moving at all. Obviously, we've given a ton of injections, so for us just to move it a little bit, we know that we've moved the bevel. But they don't, so it's really, I think, important for them to really do that whole turn so that they know and we can see that they're doing that aspiration in a second plane. And then the other thing is just when students are giving the IA, to have them work on the molar teeth and completing the molar teeth first, so that if the patient starts to lose anesthesia, they can just administer the MI rather than having to give the IA over completely again. So that was something I actually did that, I think, when working with Nick. You had suggested that he do that, and it worked really well because the patient did lose anesthesia, and we were able to just give the MI instead of giving the whole IA again. And then the last thing, just that students know all the information before they're administering. I know you guys have sent out a couple messages about making sure that we pull the students away to go over everything before instead of doing it in front of the patients, which I think has made a big difference. They're a lot less nervous when they're not in front of someone that they don't really know going over all that stuff. So.